And thank you for those who could join in. And I would like to, before I introduce our esteemed speaker, Dr. Minas, I would like to give a brief, overview of who we are, so that those who do not know us and do not know Breast Cancer Hub, so I can just walk you through a little bit. So I am Dr. Lopa. I am the founder and president of Breast Cancer Hub, and I resigned in 2017 from my career to build BCH as a full-time pro bono voluntary service to bridge the gap between the developed and the developing countries, because I knew that being a cancer research scientist all throughout my life and cancer research professor, I knew that how lives are lost to breast and other types of cancers because of late detection, taboo, ignorance, and inaccessibility to healthcare facilities, and also proper guidance and management. So to gap that, there are simple solutions at the grassroots level that we can provide, and that's where the inception started. But it started with breast cancer, but now we have diversified into different types of cancers. So how we do that is basically population outreach. We reach out to the people, teach them about early detection and prevention. We have built early detection cards of all types of cancer. We have for breast self-exam card in 22 languages with the help of our BCH volunteers. We have translated it so that we can reach to the population who don't even understand English. But then during the webinars or the community outreaches that I'm doing, I'm also giving my contact information. So basically kind of taking accountability. So if anyone faces any issues, they can reach out to me and I can navigate them towards the right resources, towards the hospital facilities. But doing that, I also realized that there's a huge financial crunch with the patients going on because the treatment is very expensive. So we have a very limited patient treatment aid because our revenue is not much. But what we do is for the underprivileged sectors, we kind of hold their hand so that their treatment is getting done. And for the low and middle income group, we try to navigate them towards the hospitals where you get the generic version, so that anyone reaching out, we can take care from end to end. Doing this, we have also adopted villages in India. Like right now, we have adopted 11 villages in Assam. We are planning to do more in the South India now. But then what we do is we go door to door, do breast cancer screening, oral cancer, because tobacco is a huge problem in the developing countries in India. So we dwelled into oral cancer screening, cervical cancer screening. So we kind of, all the suspicious cases, they are villagers, they have no money. So even health is not even their priority, food is their priority. So what we do is we take them to the hospital. We collaborated with the local cancer hospital in Assam. And then this is in Kachar district in Assam. So we collaborated with, Kachar Cancer Hospital and Silchar Medical College. So we take patients over there. We make sure that they are getting treated, their treatment expenses, everything we take care till they get the government aid, which is like government of India aid. But in the similar way, we have done also in Africa, in Sierra Leone, we are helping the patients over there. But I do a follow-up of each case because so that the aid is actually properly utilized. So and doing all of this, I realized that support groups are missing from many parts of the world, like the way we have it in the US. Because in India, when I would travel all across India doing the outreaches, I would meet patients who would ask me, like, what is the meaning of support group? And that's how I felt that I should bring everyone together. So we have small support groups spread out, but we also have a very private WhatsApp group, which is connected through trust and love. And I do not discuss any patients. So this is like more like a trust. And then we have oncologists, we have nurses, we have the patients, we have the survivors whose experiences, is invaluable. So doing all of that, also like research, I couldn't give up the research. So research, I'm trying to work into the untapped sectors, like making changes in the healthcare policies. So our research is IRB USA and IEC India Ethics Committee approved. And we are doing a lot of clinical data analysis between comparing the developed versus developing world. So, and then trying to make changes in the healthcare policies through epidemiology study and other, and trying to find the underlying factors. procedures. So yes, that's what we do, and a lot of one-on-one counseling every day I'm doing with the patients. So please reach out to me if you need any help, and whatever way I can. All our services are free of cost, and every donation goes for the mission. So we are in USA, everyone, we are volunteers, so we do not take anything, and then also like our services are all free of cost. So we have many leadership programs. I'm mentoring students, and they are the future leaders. And we have also done a lot of COVID response in the USA and India. In the villages, we have provided food to, like, all the families. We have adopted those villages. So it's kind of like taking care through and through. So that's how we function. And I cannot be more grateful to the BCH volunteers. And we are like a family, and our support group is like a family, and we are built with trust. So that's who we are. And saying that, I would like to, introduce you all to our only speaker, our esteemed speaker, Dr. Minas Chrysopoulo, and I'm going to say Dr. C because that's how he prefers. So first of all, I would really like to thank you, Dr. Minas. I mean, I know how precious your time is, but in spite of that, you have made time for our breast cancer hub. Can't be more grateful for that. So let me give a little bit of introduction about Dr. C. Dr. C is a board-certified plastic surgeon, breast reconstruction surgeon, and microsurgeon, and president of PRMA Plastic Surgery in San Antonio, Texas. He specializes in state-of-the-art breast reconstruction with a particular focus on perforator flap breast reconstruction, techniques to maximize aesthetic outcomes and restoring sensation after mastectomy. Under Dr. C's leadership, PRMA has become one of the busiest breast reconstruction practices in the world, routinely welcoming patients from across the globe. Dr. C is certified by the American Board of Plastic Surgery and is an active member of the American Society for Reconstructive Microsurgery and the American Society of Plastic Surgeons, for which he serves on several breast reconstruction educational committees. He has authored and co-authored several book chapters and scientific articles in peer-reviewed journals on breast reconstruction related topics, and is routinely an expert speaker at regional, national, and international academic meetings. Dr. C has founded Toliman Health, a digital health company committed to helping physicians, healthcare organizations, and industry improve patient experience and outcomes via empowering shared decision-making technology. Toliman's flagship product, the Breast Advocate app, is the world's first shared decision-making app for breast cancer surgery and breast reconstruction. Breast Advocate provides anyone with a breast cancer diagnosis or at risk of developing breast cancer a much-needed voice in their breast cancer surgery decision-making. So we are honored to have you, Dr. Minas, and the platform is all yours. Thank you so much.
Thanks so much. Whoever wrote that bio needs a raise. That was too kind. Thank you very much. It's a pleasure and honor to be here. Thank you for joining us, everyone. Happy Independence Day for those in India. Let's move on. I'll share my screen. There's a lot of stuff to cover here. Forgive me sometimes if I go through things too quickly, but hopefully we can address some things at the end. Lopa also sent me some questions that folks wanted answered, so I've interjected those throughout the talk. So you've heard all about me. These are my disclosures. Please check out Breast Advocate. A lot of passion and effort went into that, certainly not only from me, from a ton of people, a ton of patient advocates in particular, that actually taught me a lot during the process of putting it together. As Lopa said, it's all about breast cancer surgery. There are lots of breast apps out there, but this one is really our niche is breast cancer surgery, and you getting the information you need so that you can have the conversation that you want to have with your care team, with your physicians. So today is basically about surgical options for breast cancer patients. I did get a few social media messages asking me to include prophylactic. So the primary focus is breast cancer, but obviously prophylactic surgery is part of that decision-making. And it's going to fall into two basic components: a mastectomy, which is breast removal. That's what a mastectomy is. There are different types. of that procedure, and a lumpectomy, which essentially preserves the breast, right? So lumpectomy is not actually a medical term. It's a term we've kind of made it up, a lumpectomy. Ectomy is a removal of something. So we're removing a lump. That's not a medical term. It's really a partial mastectomy or segmentectomy, but lumpectomy is used really colloquially. When you look at the different procedures that are available, whether you have a cancer diagnosis or you're high risk, you have the option of these based on this table. Obviously, if you're a high risk patient, you're not going to have any need for lymphedema surgery that we're not going to really talk about today. And there's also no indication for a lumpectomy or oncoplastic surgery, which is another type of lumpectomy. There's no indication for those procedures in patients who only have a genetic predisposition and do not have a cancer diagnosis too. So we're going to be talking about pretty much all these things today. Starting off with lumpectomy, what is that? Basically, it's removal of just the tumor and a segment of tissue around it to make sure you've gotten all the way around the tumor. The breast surgeon will remove the tumor and then it's inked. So when the pathologist looks at the tumor, they are basically looking for how far the tumor extends to the edges of the specimen, and they want to make sure that there is no tumor touching the ink that's placed on the specimen after removal. So if there's no ink on the margin of the tumor, then by definition, that means that the tumor resection is complete, that you have pathologic negative margins, which basically means you got it all, right? So that's what we want to see. Lumpectomy is usually followed by radiation in the vast majority of people. There's a subset of folks over the age of 70 that don't need it, but most people are going to be having radiation recommended. You're a candidate for a lumpectomy if you're early stage breast cancer, including triple negative. You're going to need some sort of localization technique if you're a patient where the tumor cannot be felt on exam. So if it was picked up by a mammogram, for example, and you can't feel a mass or lump, you can't feel anything abnormal, then a localization technique is particularly important. And there are different types. Some places will insert a wire into the tumor ahead of time to guide the surgeon, and other places use a radioactive seed, which is far more pleasant and efficient, and that helps the surgeon find the tumor. If you've got a large tumor, traditionally, you weren't a lumpectomy candidate. But now we're giving chemotherapy up front before the surgery. That's called neoadjuvant chemotherapy. And the goal there really is twofold. The first goal is to shrink the tumor so then it becomes small enough so that you can remove it only with a lumpectomy, and you don't need a mastectomy because you've downgraded the tumor size. And then the other good thing about neoadjuvant chemotherapy, giving chemotherapy beforehand, and then waiting to see the response in the cancer, now you know whether the chemotherapy worked or not, right? So there's lots of benefit there up front. Traditionally, we would do the surgery first, and then we would give the chemotherapy that we thought was the best fit. These sorts of cancers, they generally react to this type of chemo, so let's give this. But now we're getting more and more into precision medicine. You really want to be more precise or as precise as possible in the chemotherapy agents that you give based on the patient's tumor. And so neoadjuvant chemotherapy allows you to kind of have to check that box and make sure you're giving the right stuff. If you've had these things, or if any of these apply to you, then you're not a great lumpectomy candidate. I'm not saying this list means that you should never have a lumpectomy. These are relative contraindications, but certainly a large tumor that doesn't shrink with neoadjuvant chemotherapy. If you've got a large tumor and a smaller breast, I mean, if you think about it, if you're a B cup and you have to remove a third of the breast to get around this bigger lesion, then you're not really saving very much. You're not conserving. You know, the term is breast conservation. You're not conserving much if you really deform the breast significantly because the tumor is large and the breast is small. Also, if the tumor involves the nipple and the areola, that's right in the middle of your breast. So if you do a lumpectomy that's in the central part of the breast, so you remove the middle part of the breast, that's never going to look good. And the other thing about lumpectomy actually is that historically this came about because mastectomies were so debilitating. They were very, very extensive way back when, not anymore. But you know, it used to be a very, very deforming procedure. So people thought, well, why are we being so aggressive? Can't we just remove the cancer and preserve everything else? So the whole point of lumpectomy is to do it in people to, number one, get the same cancer benefit as you would with a mastectomy or better. And number two, do it in a non-deforming way. So if you've got a lady who would end up looking deformed because of what you've done to her as a surgeon, because you removed a big tumor in a small breast, or you removed the middle part, the central portion of the breast, and then just kind of hiked it together and it doesn't look good, you haven't checked that box. You've rightly checked the priority, which is cancer first, but we can do this in a cosmetic way. Many, many times we can get good cosmetic results. If you've got a genetic predisposition, so if you're, for example, BRCA, obviously there are lots of different genes that increase your risk of breast cancer. That doesn't mean you shouldn't or cannot have a lumpectomy. Some people know they're BRCA positive and they want to preserve their natural breast because they feel there's nothing wrong with it yet, and they just want to monitor it, and that's okay. It's just with the genetic component, you want to think, you know, prophylactic mastectomies and have that conversation. So it's a very well-informed decision in women who choose not to do it. There are different places you can put the scar on the breast to minimize the impact of the lumpectomy. Basically, you want to limit the incisions to around the areola if possible, or in the crease or in the armpit. There are lots of times that you see incisions everywhere else on the breast. And we kind of think, as plastic surgeons, we think, oh man, why didn't they use something a little bit more cosmetic? Sometimes it's a very, very difficult tumor to get access to. And in that situation, again, you always prioritize the cancer. It's cancer first, breast second. But whenever possible, the incisions should be placed in places where they are least visible. These are the sorts of patients that I see very frequently. These aren't bad results. Bear in mind also, as you heard, I am a plastic surgeon. I reconstruct people. I don't see the people who are really, really happy with their lumpectomy results. So by definition, the folks that I see are unhappy. So I don't see the results that look great. I just see the results that look okay or bad, right? So just to be clear, you know, if you've got, if you're a large-breasted woman, you know, you're a double D cup breast, you have a lumpectomy, you could end up looking like you've never had a surgery. You could look great, right? So this is very patient dependent on the situation. So here you can see the lady on the left, she had a lumpectomy on the left side and then she had a radiation. You know, when you quickly look at her, it's like pretty close. She's not happy because the whole part of the lower breast really has been significantly impacted. And the other thing is, when you do a lumpectomy, even when the breast looks pretty good after the lumpectomy, when you add the radiation that you need in order to decrease your risk of recurrence, that's what radiation does. When you add that radiation speeds up and heightens your scarring. Basically, it kicks that fibrosis up a level. And so women can look pretty good after a lumpectomy and then not so good after the radiation. And so here on the right, you can see a lady who's experienced that very thing. She actually said, I didn't look too bad. I was actually very happy. And then I finished radiation. And over time, it's gotten worse and worse and worse. And we see that a lot. For plastic surgeons, radiation is the gift that keeps on giving. And you can get these sorts of unfavorable results, right? So the lady at the top of the screen, she had a lumpectomy and then got very, very aggressive radiation. And this is her result. The lady on the bottom of the screen, lumpectomy on the left side. Before her surgery, the left breast looked like the one on the right. Radiation shrinks tissues and it changes things. So these are the sorts of results that we see because these are the unhappy patients. And then we can always address things after the fact. So the same lady, we did a breast reduction on the right side just to improve her symmetry. And she's super happy. There are plastic surgery techniques that you can use at the same time as a lumpectomy in many patients, which will help prevent the results that you've just seen. So plastic surgery, we can lift breasts, we can rearrange tissue, we can reduce breasts to make them smaller. So a breast lift, a breast reduction, most of you probably know those terms, have heard those terms before. You can design a breast lift or a breast reduction in such a way that you incorporate the lumpectomy at the same time. So that way you end up maximizing the cosmetic result while prioritizing the cancer care. And actually getting a breast reduction at the same time as your lumpectomy from a cancer surgical standpoint is even more aggressive than a regular lumpectomy because it allows you to remove even more tissue because you're reducing the breast. It's just doing it in a plastic surgery way. So here we have a lady who had a left-sided breast cancer, and she, the top picture is before her surgery, the bottom picture is after her surgery, and she had an oncoplastic procedure. So basically a lumpectomy and a lift at the same time. And I think you can barely see the scar around the areola on both sides, and you can see this subtle change in the shape and a little bit the size of the breast. And this lady's super happy and she doesn't have a deformity. This is one of the questions that I got, why, so I think that the question was phrased, people are given the choice of a lumpectomy and mastectomy, and then they choose a lumpectomy and end up getting a recurrence. And the implication was that this happens a lot. So basically, why do you get so many recurrences after a lumpectomy? Well, the data doesn't actually back that statement up, okay? So we know that in women who have early stage breast cancer, a lumpectomy with radiation, and that's important, with radiation is essentially just as good as a mastectomy, whether you're looking at recurrence rates, survival, disease-free survival, it's essentially the same. What isn't the same is if you don't add the radiation to the lumpectomy. So if you only have a lumpectomy and you say, nah, I don't want to do the radiation, I've heard bad stuff, I don't want the side effects and all the rest of it, then you do have a higher risk of recurrence. So when I saw this question, I was kind of thinking, what are the possible explanations? If this is the experience of some people, is it because they didn't understand that having a low risk doesn't mean you have no risk? Okay, so a physician or someone can tell you your risk of recurrence is low. And then when that recurrence happens, some people feel, oh, I wasn't supposed to get a recurrence. It was low risk. Well, yes, it's low risk and you are unlucky. You still got it, but the risk isn't zero. So low risk doesn't mean you're not going to have it. It just means your chances are more that you won't have it, right? So how you deal with that risk conversation is important. Maybe some people didn't get the radiation after the lumpectomy. That's a reason. That would be a reason to explain a higher than expected recurrence rate. Another reason is if patients don't get the right systemic therapy, right? Because breast cancer is not really, breast cancer is a systemic disease. You've got to treat the whole body, okay? It's not, as much as us surgeons want to go around beating our chest that we're curing cancer, breast surgery is not really anywhere near as important as systemic therapy when you look at the big picture, okay? It's a systemic disease. So it doesn't matter what surgery you get. If you needed systemic therapy and you didn't get it, or you didn't get the right stuff, then your risk is going to be higher. And then finally, the other reason I could think of in this situation is if you've had a lumpectomy and you've got a genetic predisposition, if you've got a genetic mutation and it wasn't picked up, that's another reason you can have a recurrence after a lumpectomy and maybe it wasn't expected, or if there's a higher rate in a certain population. So that brings me on to mastectomy. So that's removal of the whole breast. Lots of different techniques, different types. A therapeutic mastectomy treats an existing cancer. A prophylactic mastectomy is a risk reduction procedure to try and prevent cancer. Again, the risk is not 100% or 0%, right? A prophylactic procedure does not reduce your risk of future breast cancer to 0. It just reduces it very, very significantly, over 90%, 95% sometimes, depending on the population. The big thing that people don't talk about, well, we're talking about it now, I guess, fairly recently, but historically, people didn't know that they would be left with permanent sensation changes, permanent numbness after a mastectomy. A mastectomy removes the breast tissue plus, and we're going to go through the different types. And as part of that surgery, your nerves are cut usually. So it's the norm. Most people will experience numbness to an extent. Some people, it's total numbness, the whole chest area on that side. If they're having a bilateral mastectomy, both breasts, then they can have numbness across their whole chest. Mastectomy, as I mentioned earlier, has come a long way. We started off, with radical mastectomy. That was a barbaric procedure. Thankfully, that's really been confined to the history books. And that would remove not just the breast, skin, nipple areola, but also the lymph nodes in the armpit and the chest muscles, right? So there's no indication for that these days. You've got to have, the only time, we even deal with chest muscle surgery is if you've got local invasion of the cancer into the muscle, in which case we remove a little piece of the muscle around the tumor. But to go in and remove all the chest muscles, that's barbaric. That's not done. So we've moved on now to the procedures have evolved to doing less, right? Less is more. And it's the same with lymph node surgery, with axillary surgery. We're seeing now less is more. Removing more doesn't mean you get any benefit, and it just increases your complication. So a modified radical basically is the next evolution of the radical. It saves your chest muscles and it's more selective with your lymph nodes. Then moving on from that, a total mastectomy doesn't automatically take your lymph nodes, and you have a sentinel lymph node biopsy. You identify which node is most important in terms of draining the breast lymphatics, and you have a sentinel lymph node biopsy. We'll touch on that a little bit later. A skin sparing is the same as a total, except it saves most of the breast skin, except for the nipple and the areola. And a nipple sparing basically just takes the breast gland, and it doesn't take any breast skin and doesn't take anything else. And of course, you can do a sentinel lymph node biopsy with the nipple sparing as well. Reasons not to, or reasons to really be pushed to a mastectomy. If you've got an inflammatory breast cancer, that's a good reason. Lots of different areas within the same breast. You can still do an oncoplastic procedure or a wide local excision or wide lumpectomy if you've got more than one area and they're close together. And there are some phenomenal surgeons in around the world that have managed to do oncoplastic surgery with different tumors in different parts of the breast. But that, that's super specialized hands. Generally speaking, if you've got lots of disease everywhere, different segments of the breast, it's very, very hard, and you're looking at mastectomy. And then the same thing goes with, if you've got a lot of lesions, microcalcifications throughout the breast, we can't get a handle of how much of that is bad. That's more likely to lead you to a mastectomy. And, if you've had lots of goes around, lots of attempts to remove the tumor with a lumpectomy, 1, 2, you have one, you always have a chance, maybe depending on the study, 15 to 25% chance of a positive margin after a lumpectomy. So you've got to be open to that potential risk of more surgery. But, we see patients that have had 3, 4, 5 lumpectomies. It's you want to pick up the phone and call the breast surgeon and say, enough already. This lady needs a conversation about a mastectomy because there's not going to be anything left. So sometimes, as the physicians will recommend a lumpectomy because the patient's a great lumpectomy candidate, but the patient wants a mastectomy. And so there are lots of reasons for that. So a big reason that I see is the desire to avoid radiation. So radiation has come a long way. There are some horror stories about, radiation burns and this and that. And, okay, we still see that. But radiation has come a long way. And the results have really, if you're in a good especially a center of excellence that does a lot of breast cancer, really the complications have been decreasing significantly over the years. The technology is way better than it used to be. It's far more targeted, so the risk of damage and complications because of damage to other organs the risk of that is becoming less and less. The one thing that we can't control is genetics, okay? And you can have 2 people, same diagnosis, same age, same everything. They just have different genetics, and one tolerates radiation really well and the other one reacts really, really badly. And by badly, I mean a lot of scarring, a lot of fibrosis. So that's one thing we can't control. But please know radiation has come a long, long way, and there are benefits to having it. Otherwise, we wouldn't be recommending it. If you've got a small breast, especially if it's a large tumor in a small breast, that generally, that increases the chances of a poor cosmetic outcome. Some people falsely believe that if they do the more aggressive procedure, the mastectomy, then they have a better chance of living longer or a much smaller chance of preventing the cancer from spreading. That's absolutely not true. And peace of mind, that's a very big deal. As physicians, we talk about statistics and data, but we're not the ones who live with the consequences of these decisions. Patients live with those. And so patient preferences need to be taken into account. We can't be telling patients what they should do and not be listening to what their viewpoint is. We need to be educating our patients with the information they need. We need to be sharing our experiences with them, but we also need to listen to what's important to them, what makes them anxious, what's going on in their lives, their support structure, their work, what they want to get back to doing, what a good outcome would look like to them. What do they need from this? I mean, obviously they want to live, but beyond that, long term, what's important to them, okay? And then you find the best approach when you factor all those things together. What I just described is shared decision-making. And that's why we developed Breast Advocate, the app. It's a shared decision-making app. This is what I want you guys to get out of this talk, and that is the information you get. You need to add that and consider it based on what you feel is important to you. And then you take that and have the conversation with your physicians to work out what the best approach is. The other breast. So let's say you're diagnosed with breast cancer on one side, and should I remove the other side too, the healthy breast? You know, this is a particularly big deal in the US. In the US, the rate of contralateral prophylactic mastectomy, okay, so removing the healthy breast in someone who's got cancer only in one breast, you know, we see that a lot. The rate of that in the US is higher than anywhere else in the world. A lot of that is to do with insurance covering it, lack of appropriate education, and what I call rational fear, right, anxiety. But there are medical reasons why you should consider it, right, that I've listed here. And there are high risk mutations, gene mutations. There are lower risk gene mutations that, you know, really family history you've also got to consider. It's different types of pathology. Lobular pathology does increase your risk. If you're having a mastectomy and you feel that you don't want to be lopsided, you don't, you know, like, how am I going to wear clothes? You know, I want to be flat. I don't want to have the hassle of being lopsided. So maybe you want to be flat chested, and in which case going flat means you've got to remove the other breast to be totally flat. Or if you want symmetry, but you also want breast reconstruction, well, if you're having a tissue breast reconstruction, we should be able to match that to the natural breast, because tissue should be able to match tissue. If you're having a reconstruction with an implant, though, getting symmetry with the other breast can be very, very difficult. And so some women that who are only candidates for implants for their reconstruction, or that's anything they have access to, some of those may be better served to get a contralateral prophylactic mastectomy too. Now, there are some situations where, you know, especially with low penetration genes, you know, not like BRCA or any of the other big hitters, you know, sometimes we're like, you know, we don't quite know what the risk is. And there's a calculator called the Ask to Me calculator that a lot of physicians use. This is a collaborative effort between Mass General and Dana-Farber. It's an awesome tool, and it lets you pick the gene, patient's age, prior cancers they've had, prior surgery, and it gives you a risk. So this can be really, really useful to really help add a number and quantify how risky is it? How risky is this going to be for me to keep my breast? And what's the risk that I'm decreasing if I remove it? So it's a very useful tool. So another question that was sent over, why are there so many second cancers in the other breast in high risk cases, right? So, you know, this is the kind of patient that, you know, maybe looks back and thinks, well, crap, why didn't I remove the other breast when I had the chance, you know? Well, it depends on what high risk means. High risk means lots of different things to different people. So I don't know how to answer that. It's going to be a very specific situation. One thing I will say is there are situations where people haven't had enough testing. And so they may be BRCA negative, and they were maybe deemed higher risk because of family history, but they're BRCA negative, then they may not get the contralateral prophylactic mastectomy, but they still had a gene. It just wasn't picked up. So the multi-gene panel testing is crucial, right? So just testing for BRCA isn't enough anymore. Now, if the multi-panel gene testing is negative, there's likely no survival benefit to the other, to removing the healthy breast. If it's positive, then there certainly may be some benefit. And then again, a high recurrence or relapse in the other breast, because a tumor in the other breast isn't a recurrence, that's a new tumor, because cancer doesn't go from one breast to the other, right? So that's a new tumor. Cancer spreads to the rest of the body, but not to the other breast. But another reason for getting another tumor would be inadequate systemic therapy at the time of the initial diagnosis. So when should we be looking at removing both breasts if you don't have a cancer diagnosis, right? So again, genetic mutation is the #1 reason. But also if you've had prior radiation to the chest. So if you've had lymphoma at a young age and you've got what's called mantle radiation, which is where your chest is radiated, your lymph nodes, your central portion of your chest is radiated, and all the way down, basically down your spine and then into your groins, potentially, that can increase your risk. There are some relative indications that we've kind of touched on already. And then the other elephant in the room, especially in the US, is the rational fear that I talked about. You know, you've got, especially when you've got, you know, celebrities now talking about, you know, everyone knows about the Angelina Jolie kind of effect or phenomenon. When you've got celebrities talking about removing healthy breasts, that fuels the conversation, it fuels that line of thinking. You've got insurance companies that cover it. So we don't have the stringent kind of workup that other countries have before signing off and before approving mastectomies in some women. It's getting tighter though, but we don't have the same that other countries do. Another question, what are your thoughts on bilateral mastectomy in a BRCA positive patient who has triple negative breast cancer? Well, I mean, the triple negative breast cancer really is more of in this situation, is more of a question about ongoing treatment. A bilateral mastectomy should be on the cards for any BRCA positive patient, whether they've got triple negative or hormone positive breast cancer. If they're BRCA, then there's going to be benefit there. In terms of screening, depending on where you are, where you live, what you have access to, annual MRI, I don't know if that's even feasible in some parts, but that should start early, and an annual mammogram at age 35. Salpingo-oophorectomy, so removing your fallopian tubes and your ovaries by age 50, also significantly decreases risk of future disease. And then if you have a cancer diagnosis, and then you're going to have a prophylactic mastectomy on the other side, you can do that at the same time as a therapeutic mastectomy or any time later. And then, you know, you're getting into nuances and conversations about radiation. And if you're going to have radiation, then reconstruction before the radiation, you know, in many parts of the world isn't a good idea because the radiation can ruin the reconstruction. So you know, I would say most places, if you're going to have radiation, then reconstruction isn't considered until all of that is done. And we'll talk about that later as well. So just kind of take home messages, take home points. So lumpectomy and radiation is basically the same as mastectomy in terms of recurrence and survival. Okay, and actually there are some fairly recent studies that are showing some potential survival benefit with radiation. So they looked at breast conservation patients, so patients that had lumpectomy plus radiation, and they compared them to a control group that had mastectomy, and there was a slightly higher survival benefit in some women. So that's an interesting kind of development. You know, it's a very complex decision. Personal choice matters. It's very important. And for me, it has to be a two-way conversation between the physicians and the patients to come up with the right treatment plan. And the other thing you got to know is whether you have a lumpectomy or a mastectomy. Don't choose a mastectomy because you want to avoid chemo, because that's completely unrelated. So you may be able to avoid radiation if you've got a tumor that's less than 5 centimeters, and you know the other criteria. But choosing a mastectomy won't decrease the recommendations for chemotherapy or endocrine therapy. Okay. Lymph node surgery. We've got to know what's happening with the lymph nodes so that we can stage you, so that we can decide what the best treatment is that we need to be looking at, what the prognosis is, whether you need radiation. All this is very, very important. So basically, patients will be given a radionucleotide or a seed, an injection that is that can be picked up with a special kind of device that picks up low-level radiation, and that's an injection that's given before the surgery. And you can also use dye at the time of surgery. Basically, both those mechanisms, both those techniques, if you inject it in the breast, those substances then travel in the lymphatics to the lymph nodes in the armpit, and then you can pick it up. You can see which lymph node is the most important one. It's the sentinel node. And that's the one we want to biopsy. And oftentimes, or usually, it's not just one, it's a little cluster of maybe 2, 3, or even 4 sometimes, but it's not just one usually, but a very, very, very small number. And if those are clear and there's no cancer in those, then we're happy that there's no spread to your armpit and the disease is confined to the breast. If the sentinel lymph node is positive, then we've got to work out, are those the only lymph nodes involved, or are other lymph nodes involved in the armpit? And then you typically need more removed to make sure. One important thing is if you're choosing, so if you don't, so anyone who has invasive disease needs to have their lymph nodes tested. But in DCIS is not invasive. So we call it breast cancer, but it's stage 0, it's pre-invasive. By definition, DCIS hasn't spread. So the argument is, why even do a lymph node biopsy in someone who's got DCIS? Well, the problem becomes if you do a mastectomy in someone who's got DCIS, and then you find an invasive component, your pathology after the surgery shows that there was actually some cancer, invasive cancer in there. Now you can't go back and do the sentinel node after the fact. So you've missed the opportunity. So any DCIS patient who's having a mastectomy should have a sentinel lymph node biopsy. And there are different degrees of different grades of DCIS, and some are more aggressive than others. And there's not 100% consensus amongst breast surgeons. Some breast surgeons always do a sentinel lymph node biopsy with DCIS. Others are more selective depending on the grade and depending on the procedure. Another question, triple negative breast cancer in gene negative patients, what's the best surgery since we don't have targeted therapy and the chances of relapse are greater? Well, triple negative breast cancer patients need neoadjuvant chemotherapy, right? Which isn't targeted therapy. The targeted therapy really is for metastatic disease, right? So we're kind of mixing and matching things here. So ideally, a triple negative breast cancer should get neoadjuvant chemotherapy. So that's upfront chemotherapy before their mastectomy or lumpectomy, whichever one, before their breast cancer surgery. And then if there's residual disease, if there's disease left over, if the chemo didn't knock it all out ahead of time, and there's cancer in the surgical specimen, then you go on to have other treatment, okay? But that's still not targeted. The systemic therapy is what determines the chances of relapse. But really targeted therapy, which is things like immunotherapy, that's really metastatic disease. And then when you look at patients with metastatic disease, surgery is really not that beneficial, generally speaking. There are certain situations that there's some benefit, some metastatic lesions, if you have single lesions or very defined lesions, bony lesions can be removed through surgery, some liver lesions now. There are very specific, some brain lesions. We have, the gamma knife There are very specific metastatic lesions and situations where surgery would be beneficial. And then also, there are some situations where now we're thinking that if the patient is diagnosed with metastatic disease de novo, what that means is the initial diagnosis is made and the patient already has metastasis. So it wasn't an early diagnosis, the patient is already metastatic. So then they still have their breast cancer in the breast. There are some situations where still removing that breast cancer has some benefit. There's some studies that are showing some slight increase in survival benefit. And then also from a hygiene standpoint, sometimes it's beneficial. If it's a really advanced tumor in the breast and it's what we call, fungating, or, it's a difficult hygiene issue, or, then for comfort and hygiene issues, you can also look at removing it. So what do patients look like after a mastectomy? Just a mastectomy. So the top pictures are pretty typical results for the patients I see. These particular patients weren't happy with their results because they didn't like the extra skin, the extra stuff left behind, as they call it. There's really a lot of advocacy work going on now, which is a very good thing, about going flat or aesthetic flat closure. Just because you don't want breast reconstruction doesn't mean you can't still have an aesthetic flat contour, a chest that helps you get dressed, makes it easier to get dressed, makes it easier, even if you want to wear a prosthesis, you don't have all this extra stuff just kind of hanging there. You don't have things kind of poking out the sides of your blouse and all this. I mean, it's a major quality of life issue. And so there's a lot more conversation going on about aesthetic flat closure or going flat. But the top pictures really are very common after a mastectomy still. The bottom pictures, the one on the left is a patient that came to me. She had a much better result than the pictures above, but she still found the extra tissue on the sides of her chest annoying. And actually the major thing for her was that she didn't have much padding, much covering over her ribs in her chest after the mastectomies. And so we did some fat injections and some scar revision just to improve the padding over her ribs and improve the side contour there. And she is much happier. So aesthetic flat closure, something else patients should really be aware of if you're thinking you want a mastectomy but don't have an interest in breast reconstruction. It doesn't mean you have to settle for a result that looks like these top pictures, okay? Breast reconstruction. So what is it? It restores breast anatomy, okay? Makes women physically whole. Some women don't need breasts to feel whole, but I'm talking about an anatomic, restoration. Mastectomies, by definition, essentially amputate a body part. So breast reconstruction restores that. Whether you feel, some women don't feel that their breasts define them and they don't feel that they need breasts for a sense of wholeness. I'm talking about physical restoration. And for some women, that then leads into their sense of wholeness, emotional, psychosocial. It has no impact on recurrence or survival. Okay, so reconstructing your breast does not increase the chances of the breast cancer coming back. Okay, so whether you go flat or whether you have breast reconstruction, your risk is determined by your initial cancer diagnosis and the treatment of that cancer. Okay, implants aren't your only option, and we're going to go through the tissue options too. Unfortunately, most breast cancer patients aren't offered the option of breast reconstruction routinely, globally. And even in the US, I mean, about a quarter of patients, even though they're told about breast reconstruction, they're not given all the options specifically about breast reconstruction. They're just given maybe just implants. Here's what we know about breast reconstruction. For those who are interested in getting breast reconstruction, it improves their quality of life. So that's always a good thing to get patients involved with research and get data from how to see how they perceive things, how they're impacted. So this is a BreastQ questionnaire, which is specifically looking at patient-reported outcomes. And so we know it improves quality of life. Age doesn't seem to be a factor because older women feel the same way. So let's talk about some myths. A lot of people think that you can't even think about getting a breast reconstruction until later. You got to have your mastectomy, get done, and then do breast reconstruction. Well, that's not always the case. Sometimes you're better off waiting, unless you're in a center of excellence that does a lot of breast cancer work, and they have a really strong radiation oncology team that works very closely with the plastic surgeons. You know, in those situations, you can still have reconstruction at the same time as a mastectomy, even though you need radiation afterwards, or radiation, you know, we think you'll need it. If you're not in a place where they're experienced with that, with breast reconstruction and radiation, then you are probably still better off, in my opinion, having all your treatment, getting radiation, finishing radiation, and then getting what we call delayed reconstruction once the radiation is done. But if that's not you and you're not looking at radiation, then chances are you can have reconstruction at the same time, which gives you a much nicer cosmetic result. It's less scarring, it's less anesthesia, fewer procedures. So there are benefits to doing the reconstruction at the same time. It is more surgery though. Immediate reconstruction is more surgery in one go. And so you've got to remember though, whenever you do more surgery, it's usually also a little bit more risky. So immediate reconstruction is associated with a slightly higher risk of complications than delayed reconstruction. But the benefits we feel and patients feel far outweigh that slightly increased risk. Radiation, a lot of women are told, or they think, oh, you've had radiation, you're not a good candidate. Well, no, that's not true. You may not be a good candidate for reconstruction with implants. If you've had a mastectomy, had radiation, you're flat, doing an implant reconstruction in that situation is possible, but the risks are definitely higher, and you're better off getting a tissue reconstruction. But certainly you shouldn't exclude the option of reconstruction just because you've had radiation or you're getting radiation. And then implants, oh, you know, I don't want implants, I don't want a foreign object in my body, and I want to stay natural, therefore I don't want reconstruction. That's often true, unrelated for people. Yes, it may be true for some people, they don't want anything man-made in their body and they just want to stay natural, but that doesn't mean you can't have reconstruction, because there are natural options that use your own tissue. The problem is a lot of people don't have access to those more complex procedures. These are the basic implant options. Most implant reconstruction, you know, what is implant reconstruction? Implant reconstruction is basically the breast tissue under your skin is replaced by a breast implant. And there are different ways to get there. Sometimes we do it all in one go, and that's called direct to implant. I don't like calling it a one step or a one and done, or that kind of description is misleading, because it implies that all patients only need one surgery and everything is done, and that's not true. Even with trying to do things in one go, about 30% of people end up needing another surgery to tune things up and make things look better, or they have a complication. By far still the most common way of doing implant reconstruction is a two-staged approach. The first stage involves placing a temporary implant called an expander in the chest, and then that creates the space. It helps us control the space, the tissue that we will then later put the final implant in. So we take out the expander after we're done expanding the space and shaping it. We take it out and we replace it with a permanent implant. And there are different products we use in conjunction with this. Something called a cellular dermal matrix is it's basically like a biologic mesh. It comes from cadavers, so humans, or there are some animal products out there too, depending on which part of the world you're in. And those help protect the implants and help us secure the implants in place. You can put the expander and then the final implant either above the muscle or below the muscle. Most surgeons in the world put it under the muscle. There's a movement, and more of us are putting it on top of the muscle. I can't remember the last time I put an implant under the muscle for reconstruction. I've been doing pre-pec, as it's called, pre-pectoral, on top of the muscle for a long time now. The issue especially occurs with radiation, because one of the main benefits for me is in ladies who don't want tissue, because tissue, for folks getting radiation, tissue is the gold standard. Okay, implants have much higher risk, much higher rates of complications in people who have had radiation compared to tissue reconstruction. But in people who aren't candidates for tissue or just don't want tissue, they don't want to scar another part of their body where the tissue came from, putting the implant under the muscle and then doing radiation causes more problems, because the radiation shrinks the muscle, and then this muscle gets really tight over the expander or over the implant and causes discomfort, pain, deformity, and there's a high chance of failure. So there is a movement to put the implant on top of the muscle more and more, with good data supporting it. The other benefit to putting the implant on top of the muscle is that you don't get the unnatural movement when you use your chest muscles. So there are some ladies that they have the implant under the muscle, they're doing some stuff with their chest, with their arms, they're moving stuff around, they're using their chest muscles. Some women work out and they're trying to do stuff with their pecs, with their chest muscles. And when the chest muscle contracts, when it fires and squeezes down on the implant, it moves the implant in a very unnatural way, and we call that breast animation. And it's very unnatural. And then it goes back to normal when you stop using your chest muscle, but a lot of women don't like it. So that's another reason to put the implant on top of the muscle. The problem with putting the implant on top of the muscle is that now you don't have the padding of the muscle, like you see in the middle diagram at the bottom. If you don't have that muscle covering the implant, now all you have is the skin and the fat that was left behind by the mastectomy, and you have a higher chance of seeing ripples in the implant. And so that's where fat injections are really important, and we'll talk about those later. Alternatives to implants, these are the natural reconstructions. By natural, I mean it's your own tissue. And it creates a more natural looking breast with a more natural consistency when you touch it. So lots of different options coming from different parts of the body. The lower belly is the #1 site that we take tissue from. That was initially the tram flap. People still do the tram flap. Now it's the deep flap. There have been different techniques that have evolved over the years that, again, more sparing techniques. So in the same way that breast surgery has evolved to spare more tissue, these flap procedures have evolved to preserve muscle and take just skin and fat. So now it used to be that we would do tram flaps and remove a bunch of belly muscle, your six-pack muscle. And if you're only having a reconstruction of one breast, a tram flap is usually well tolerated by most people. The real problem arises when you're doing both breasts and you remove both six-pack muscles, both sit-up muscles. So now the lady can't do a sit-up, and more importantly, her whole core strength is impacted, and now she's got back pain, and now she needs physical therapy, and then she has these long-term chronic abdominal issues. Those are much higher when you remove the abdominal muscle with the tram flap procedure. It's still being performed globally, but really the DIEP flap now is the gold standard. The SIA flap is even less invasive because you don't have to go into the stomach muscle to find the blood vessels that we need to connect. With the SIA flap, the blood vessels travel on top of the muscle, so it's even less invasive. But both the DEEP and the SIA flap completely spare the muscle. The problem is the SIA flap, not everyone's a candidate for that because not everyone has the right anatomy. The back is also a good source of tissue. The latissimus flap is a workhorse. That's a good procedure. It's stood the test of time. A lot of people don't like it because it takes your latissimus muscle. There are ways that you can save some of the latissimus muscle, but still, for a lot of for high volume specialist centers like us, we don't really do latissimus flaps very often. It's more of a secondary procedure. And then there's also the buttock and the thighs that provide flaps, different procedures that, depending on how you carry your tissue, you can have any of these surgeries. So the DEEP flap is the gold standard these days. It's a complex procedure. It preserves all the muscle. It just takes the blood vessels that feed the skin and the fat of the lower abdomen, and then those are connected to the blood vessels in the chest. When you preserve the muscles and the nerves that power those muscles, then that significantly decreases your risk of abdominal problems. And then the other benefit we love with the DEEP flap is that it allows us to restore feeling. As I mentioned, mastectomy leaves you numb, at least many women. So when we do our DEEP flap surgeries, we look for a nerve that supplies the skin to the belly, and we transplant that nerve with the DEEP flap and connect it to a nerve that's been cut by the mastectomy, and we call that true sense. And that helps restore some feeling. And the feeling that's restored is not as good in most women. It's not as good as Mother Nature, but it certainly beats a numb breast. It beats the alternative. And in some women, the sensation is incredible. The most important thing is that protective sensation is restored, because if your chest or breast are numb, your skin doesn't feel extremes of temperature. We've seen people from other places that have been reconstructed in other places that come to us with burns on their chest because they put a hot compress or something on their breast because their breast was achy, and they've ended up burning their skin because they couldn't feel anything. So restoring feeling is a big deal from a protective standpoint, as well, of course, for the lady who can now feel a touch. Even if it may not be erogenous, be feeling a touch, feeling a hug, that's a big deal. So this is, I had I've got a bunch of surgery photos and stuff, and I didn't know what to include. I know some people are squeamish. So this is what I do most days of the week. This is microsurgery. This is what we do with our tissue transplantation procedures. What you're seeing here is the blood vessel from a DIEP flap being connected to a blood vessel inside the chest under the ribs. So this is on top of the lung or the heart, under the ribs. And we're using that suture. This is under a microscope. That suture is thinner than a human hair. And that blood vessel, that particular one, I think was like 1.5 millimeters in diameter. So that's why it's called microsurgery. The benefit of microsurgery is that if you just take what you need, you spare the muscles and you lower the risk of complications. That's the take-home message. The downside to microsurgery is you need specialized training. You need a high level of experience to get the experience you need to get the good outcomes, to make this reproducible and have very, very high success rates. So, you've got to look at specialist centers, at least most people, and many people unfortunately have to travel. This is what it looks like afterwards when we're done. And you see the two blood vessels connected here. That's the artery and the vein. These two, artery and the vein, that blood that supplies blood to the new breast going in and blood coming out. And this is a nerve reconstruction. This is the nerve in the chest attached to a nerve going off into the tissue. So this is what's going to supply feeling to the new breast. So that's pretty cool. Other things, other types of breast reconstruction, fat grafting. This is really a very, very useful adjunct. So we do fat grafting in conjunction with the other types of breast reconstruction in our practice, and we use it basically to make the results better. So after a mastectomy, you can have some contour issues. You can do liposuction, take fat from one part of the body, purify it. That's what it looks like when it's been purified, nice gold. That we call that liquid gold right there. And then that liquid gold is injected under the skin to address contour issues from the mastectomy. You can use it to add volume, add size, and really importantly, we use it a lot on top of implant reconstructions to help camouflage the implants more, especially now that we're not putting them under the muscle. And there are other techniques too that try and reconstruct the whole breast only with fat injections. So that way you get a tissue reconstruction, but you don't have to have the transplant of tissue from another part of your body, which of course leaves a permanent scar wherever you take it from. So some women want the natural reconstruction, but they don't want the final scar. If you're smaller breasted, if you're bigger breasted, it takes a very long time and many, many procedures. If you're smaller breasted, reconstructing an entire breast becomes more realistic. You still need several procedures. And there are some external expansion devices that basically suck on the outside of the breast to help create a bigger space into which you can inject. Well, it's not really a space, it's more of a matrix, but a bigger area in which you can inject more fat, and it helps more fat stay. Because a lot of the fat that we inject with this procedure, with fat grafting, it doesn't all stay. You get about between 30% and up to 50% sometimes can get reabsorbed. That's why women need, oftentimes need more than one fat grafting procedure. Generally speaking, studies have looked at who's happier, right? So, it's a loaded question. Long-term, patients tell us, the ones who have had tissue reconstruction tell us that they seem to be happier than the ladies who have implant reconstruction long-term. Implants can, I'm not here to bash implants. You can get a great reconstruction with implants, but you have a higher risk of ongoing issues. If you go with a tissue reconstruction, you're much more likely to not need future surgery. So implants can have, there's depending on the study you read, 10 to 25% chance of needing more surgery within 10 years because of implant-related problems, or the recommendation to replace the implants every 10 years, which we don't all follow. Personally, I don't make my patients replace their implants every 10 years. I only do that if there's an issue. But anyway, patients seem overall happier. So some results, this lady had a right-sided breast cancer. She had a 2-stage reconstruction with tissue expanders. First stage tissue expander at the same time as her mastectomy. Her nipple sparing mastectomy was performed through an incision in the crease. We put in tissue expanders. We expanded her up. Then we took her back for a second surgery. Took out the expanders, used the same scar, and we did some fat injections to cover the expanders. The final implants, and here she is with a final result. This lady had a right-sided mastectomy and radiation, so she came to us as a delayed patient after all her treatment. And on the left, that's her after 3 surgeries, 3 stages. As I said, the one and done. Sure, this lady could have been done after 1 surgery, but there's no way she would have looked as good as this. So the first stage was the first reconstructive stage. So once all her treatment was over, she got a left-sided skin-sparing mastectomy because she wanted a prophylactic mastectomy on the other of the remaining breast. And then we did deep flap reconstruction for both breasts. You can see here the difference between an immediate reconstruction. So when you do the deep flap reconstruction at the same time as a mastectomy, it looks like the left breast, her left breast. So right side of the screen from where you are as you're looking at it. When you do a reconstruction delayed, you now have to add a bunch more skin so that you get the same breast silhouette, which is why she's got that big patch on the side that she'd had the initial mastectomy and radiation. And you can still see the shading, the edge of the radiation. If you look at the before picture, you can see the edge of the radiation, that pigment, that's all pigment change from the radiation. And if you look at her final result, the after result, you can still see the shading at the edge of that radiation over the upper chest. You can still see that same line. So that pigmentation does change, but a lot of the times it doesn't quite fully go away. And then here she also had nipple reconstruction as part of her revision surgery. So we did the reconstruction, and then we did a tune-up. The tune-up involves scar revision, usually liposuction, fat injections, nipple reconstruction, and then her final stage was the tattooing to give the reconstructed nipples the color. This is what can happen when women who have implants get radiation. So on the right side, and again, to be clear, thankfully, we're seeing this less and less as radiation gets better, as radiation techniques and technology improves. Now with pre-pectoral implant reconstruction, this appears more or less likely. It looks like this is less likely, but unfortunately, we're still seeing it, okay? I don't want you to think that this will happen if you've had an implant and now you need radiation. I'm saying you're at risk of this happening. So here the implant basically is exposed. The skin got so thin, the quality of the mastectomy wasn't great. The tissues that were left behind were very, very thin. She's not a very big person to begin with. And so now all that was covering the implant was this very, very thin tissue, and things broke down. And when you have an exposure like this, you can't salvage it. There's no way to save it. So what did we do? We removed the implant. We removed all that really paper thin skin that was terrible quality, and we replaced it with deep flap from her lower belly. So now she's got a much more normal breast contour. She can wear a bra, bathing suit, whatever she wants. She didn't want a nipple reconstruction, but now she's whole, pain-free, and natural. I included this lady. This lady's actually a cancer. She was diagnosed with cancer, but this is a good also a result to show for those of you who are looking at prophylactic surgery, for a gene mutation, who don't have a cancer diagnosis, because you're more likely to look like this. So this lady had previous breast augmentation, so she had cosmetic implants in place. Then she developed a right-sided breast cancer. So she had her she wasn't a candidate for nipple sparing because her tumor was behind the nipple areola, right behind it, involved it actually. So we had to remove the nipple areola complex as part of her mastectomy. So she got a skin sparing mastectomy and DIAP flap reconstruction. But this could easily have been a BRCA positive patient. Most BRCA patients that I see in my practice choose nipple sparing, but even some genetic patients are choosing skin sparing because a nipple sparing approach still saves a few more breast cells. And so your lifetime risk of developing cancer is still a little bit higher than someone who has a skin sparing mastectomy, but it's a very, very small percentage lifetime risk. And remember, risk reducing surgery never reduces your risk to zero, whatever you do. So again, this lady, multiple stages. This was, if you include the nipple areola tattooing and all her surgery together, this was 3 stages. First surgery was the mastectomies with the immediate reconstruction with deep flaps. Second surgery was nipple reconstruction, scar revision, fat injections. And then the final step was in the office, nipple tattooing. And then sometimes implants don't work out, like we've said. This lady had a left implant reconstruction and, she wasn't happy with what she was left with. And so she needed more skin. So again, best way to reconstruct this is with more tissue. So we can reconstruct the silhouette and bring back what was removed to help restore the overall shape. It does mean she needed a patch of skin, but she's got a very nice contour now. And she also got a lift on the right side just for better symmetry. That's it. I think that's enough. Once again, as you heard, please check out breastadvocateapp.com. It's everything you just heard is in there and then some. So you download it, it's free. And then take what you learned to your doctor and talk it over. That's it. Questions?
Thank you so much. Yeah, thank you so much, Dr. Minas. That was, let me just change to the gallery mode. So yeah, that was amazing, how you covered from all angles. And, I mean, it's like a huge resource and huge information, so that if anyone has any concerns, with all the, the options given, so they can definitely, I will recommend to see your video so that they get all the ideas, because that's so comprehensive and it's so essential. Because I face it every day from the patients, and I try to do my best. And coming from an expert like you, it will be like amazing for a huge resource for the patients. And with the genetics concerns that you have said, it's so important, because it's not only about the BRCA mutation. And even in the US, when I'm talking to the patients, I ask them, like, did you do the genetic testing? They will say, no, I do not have in the history. So our doctor said it's okay, but I said, it's not about the BRCA only. There are so many, like being, my specialization being genetics and, cancer immunology, I know that connection and all of that. And I'm like, you have to do the panel. It's multi-panel testing. So there are so many high penetrance, intermediate penetrance genes. So yeah, so thank you so much for bringing all those, into the presentation and being so detailed. I'm so grateful to you on behalf of the breast cancer family. So I would like to open the session for question answers from our guest over here, please, for Dr. Minas.
I have one question. Can I ask?
Yes, okay. Please, Dr. Chaturvedi.
Dr. Lopa, the session has been exceptionally great. Thank you very much. Thanks, the doctor.
Thank you.
I have one question. I know a lady who is about 50 who doesn't have nipples at all. She had 2 children, never breastfed. Is there any danger of her getting breast cancer?
So she's got breasts, no family history, What was that? What was that? And no children, not breast, and she hasn't breastfed. And you're saying, does she have a risk of breast cancer?
No trace, no history, nothing. She's very healthy, absolutely fine, entered menopause, but she never had any nipples at all. Nipples probably, I mean, retract in the retracted mode.
Mhm.
And she never breastfed also. She had 2 children. Generally, I read somewhere that retracted nipples can cause breast cancer. Is there, is it a fact? And what has been your experience with such cases?
I don't know any data that shows that retracted nipples increase the risk of breast cancer.
So yeah, thank you, Dr. Meena. So I can also chime in over here if that's okay. So basically, Dr. Chaturvedi, so the symptoms of breast cancer, we always say that inverted nipple, and that's I think where you're going, because in all the breast self-exam cards, we say like look for the inverted nipples. So, but if someone is inherently having the inverted nipple or retracted nipple, and she's born like that, that doesn't mean that like she is going to develop breast cancer. So it is more like if you have a normal nipple and it is retracting, so that can be an alarming sign for breast cancer. You see what I'm saying? So someone who is born like that or has been always having since the childhood a retracted nipple or inverted nipple, so that doesn't mean that that is increasing, and there is no such data to say that. But if a normal breast look, and that's why we have to do the check, like stand in front of the mirror, understand the look and feel of the breast. And if you see suddenly there's a retraction with other signs that we always mention, she has to inform the doctor and go and do the screening mammogram followed with ultrasound if she has a dense breast.
Excellent. She was born without nipples. She was born without nipples.
Yeah. So then I don't think it's a concern at all.
Okay. My doubt is clarified. Thank you so much.
Thank you. Yeah, any other questions? You can please unmute yourself, and Dr. Minaz is an expert, so you can directly interact with the Dr. Minaz. Hi, Anjali ji, thanks for joining in.
Doctor. Hi,
Uma ma'am. Yes, thank you for joining in, Uma ma'am.
Yeah. No, I just want to know because, as you know, 23 years ago, I don't know, my surgeon decided on a full mastectomy. And of course, I also told him I want to just throw out the cancer from my body. Do you think it also was because my elder sister was diagnosed with stomach cancer, and though the doctors gave us 6 months, but she passed on within 3 months because she didn't want any really treatment. She just had the aspiration for a bloating stomach, that's all. So I don't know. Was that a wrong decision to have a full mastectomy? Now I'm wondering. That's it.
Oh, it's impossible to know. You may have had other options, but it may have been the absolute best decision you could have made. That's unfortunately, I think there's probably more harm to be done here for you if you start second guessing what happened back then.
Yeah, I know now. There is no
you know what I'm really happy about? I'm happy that you're on the call to even ask this question. So the treatment that you got obviously worked.
Yes.
Right. So I would look at it that way. It's so hard to, and even as physicians, we experience this all the time. And, we have other physicians that question. I often find myself, well, actually not anymore, but I used to find myself, when you have partial information, it's a very dangerous situation because you make potentially dangerous presumptions and conclusions that aren't based on all the facts. Yeah. So don't do that to yourself. Don't second guess. I think you're here, and that's what we need to focus on. There's a really good chance you got absolutely the perfect surgery. But unfortunately, we'll never know.
Yeah.
I hope not.
Yeah, no,
No.
that's wonderful, Dr. Minas, to say so, because I don't think at that point you went through any genetic testing also, because I think the doctor did the best because your sister had another type of cancer. So, and you are here today with us, and that kind of shows that it was the right decision, right, Dr.
I think
Minas?
so.
Yeah,
I think
absolutely.
so.
So, yes,
And
Ken,
also,
would you
as
like?
you said, the treatment of 45 days of radiation after my full mastectomy maybe helped also. Now that I heard for Dr. Mina saying that how important it is to have a subjective treatment after the mastectomy or lumpectomy, maybe that also helped a lot. Of course, I never had any side reactions for anything. So that's maybe God's blessing again.
Yeah. Yeah, absolutely. Thank you, Uma ma'am. So we would like to take the question from Ken, please. Ken has raised her hand.
Can you hear me?
Yes, Ken, we can hear you.
Yeah, I'm a colleague. I'm a plastic surgeon. And the question, I'm so happy you guys did a wonderful thing organizing this forum.
Thank you.
And my accolade goes out to all of you and to Minas, whom I do from time to time, because we talk about deer flaps and talk about neurotizing of the deer itself and how to do it and all that goes with it. So it's a good thing that people can tune in, ask questions, and be reassured. So I think the future is what you guys are doing, which I very much love, is that all specialty coming in and allowing the patients to lead us, not we leading them, but they telling us what they feel, and we make them participants of every decisions we make along the line. And I think it's a wonderful thing. So I'm highly, highly happy with all of you for what you're doing.
Thank you so much,
Thanks,
Dr.
mate.
Ken. Yeah, thank you, Dr. Mina. No, thanks, Dr. Ken, for joining in and acknowledge the efforts. I mean, what I'm trying to do is bridging the gap, because so this video will go to Africa also, to India also, and other like Malaysia and all other countries our patients are connected to. So when they get this information, like all these types of the flaps being used, because everything has its own pros and cons. So I think this is so wonderful, the presentation of Dr. This is like, I'm so happy that now, we can help and reach out to the population who didn't even know that these things exist. And that was the purpose of this webinar, actually.
Yeah, to be honest, yeah, it is wonderful, really. Yeah, it is wonderful because, like I would always say, there is no right or wrong here. What we put at the center is the patient. And we need to have the courage as surgeons to say, look, this is what my unit offers, and this is what we can do for you. However, there are other units that have other things more than we have. And this is part of the consenting, translating the consultation into operation. It helps the patient a lot to say, look, Mr. A does this. This is what we in our unit do. And if you're happy, we will do it this way. But there are other things other people do. So in that way, the patients are not left or are not misguided. So it's a wonderful thing you are doing.
Thank you. Thank you, Dr. Ken.
Great to hear your voice, Ken.
Thank you so much, Minas.
Yeah, now we've messaged, now we've spoken. Now I've got to, next is I've got to see what you look like.
Now
And then we'll get to having a drink in person. How about we work on that?
Now, when we do that, obviously, there's no problems at all. But, all of you are doing great job, because the problem with, I hope that the future of breast reconstruction and the breast cancer, we will be able to sort women out, because it bothers me a lot. And, whoever does our job, understand the pain these women go through, understand their concerns, their family, their anxiety, losing their femininity, all these things goes a long way. So whatever we do, we should always remember, because there's a saying that goes, I see the patients, you have to see your patients through the eye of being a patient. Hello?
Yeah, absolutely.
It is only then can you understand what they are going through, because if you don't measure yourself like a patient, you can't understand their pain. And I started being a good surgeon only, and I tell you the trick, when I see the patient, not like a patient, but as a family person, that in the night, what would they be thinking? What would their pain look like? What would their medication look like? It is only then can you now really treat them properly. But if you see them as, oh, not relative, not this, then it's just one of those things, isn't it?
No, absolutely. No, that's really nice thought. And I hope that, all the oncologists and the surgeons, that's basically the physician fraternity, they think the same way, then our patients will be they will feel at home. So that's so important with the treatment, because it's the psychology, it's the positive effect, and it's multidisciplinary. It's like, you have to have that support system. It's more like palliative care from the beginning. Right.
Yeah, exactly. We're all family. We're all family.
Yes, absolutely. No, thank you so much, Dr. Ken, for joining in. And if we do not have any other questions from our guest, then we would like to then close the session by thanking everyone who joined in today. And we cannot be more grateful to Dr. Minas for your extensive talk and describing each and every angle of after diagnosis, what are the different types, and what to do next. And I love the fact about giving the challenges also that you have faced, and showing the pros and cons, so that our patient fraternity, they are exposed to the truth and what they can do for their families. And I know that in many places, this kind of advanced surgeries can't be an option because of the infrastructure and the hospital facilities, but at least our patient families can go and ask the oncologist, like this, can they have this option? Or like as you said, lumpectomy versus mastectomy, then the invasive surgery. So there are many aspects that you covered which can be taken care even in the local hospitals, that many places that in the developing countries. So thank you so much.
It was a really great educative session. It was a lovely educative session.
Thank you. Thank you
and
so much.
Said that, when doctor said that, I was just remembering those years. There was nothing called prosthesis at that time, doctor.
Okay.
So I never even bothered about it. I said, okay, I just accepted. Okay, I'm not there. That's it. So, and I was one of the first ones, Dr. Loper, to volunteer at HCG to have the genome test. I got the genome test. Yeah, and I got it free.
Nice. Very nice. Very nice. And yeah, and I would also always request the patient and the caregivers to please ask about the family history, about the genetic test, so that I feel like it's your own body and you are the best advocate and you have the right to know. So by saying that, I would like to close this session today by thanking Dr. Minas. Thank you, Dr. Ken, for joining in, and thanks to everyone who joined in today. Thank you very much. Thank you.
Thank you.
I'm happy that I could attend it. Thank you, Lopa. Love you.
Love you. Bye.
Bye.